Good afternoon, everyone. This is Brenda Cruz Scotton with Proceeds National Center for Training, Support, and Technical Assistance. And I just want to thank you for taking the time to be with us today. We will be starting in a couple of moments, so thank you for arriving a couple of minutes early. And I just wanted to acknowledge your presence and let you know that we will be getting started in just about 2 or 3 minutes. So please hang tight and we'll be starting very soon. Okay, good afternoon and good morning, possibly to some of you. Again, thank you so much for joining us today for our second session of our summer webinar series sponsored by our Capacity Building Assistance for Health Equity Program, CEBA for Health Equity for short. Thank you again. My name is Brenda Cruz, and I am manager here at NASA's National Center for Training Support and Technical Assistance, Manager of Training and Distance Learning. And we have a great session of information planned for you today, and we shall begin. Okay, so as you may have noticed, all of your lines are currently on mute. We will keep the lines on mute throughout the entire session. We will be taking questions. We will be using the chat box. If you have any questions, comments, feedback, please use the chat box. At the moment, we are still waiting for a couple of individuals to log on. So hopefully, while I get through the first introductory segment, we'll have a couple of the other individuals will have joined us. So these are today's session guidelines. I already explained that the lines are on mute. The session is being recorded. If you're interested in receiving the recording, please contact me directly, and we will email you the recording. And we're going to, and please, we encourage you to use the chat box. I also included this hashtag in the chat box. This is our official program hashtag. You can use this program hashtag on our Facebook, Instagram, and Twitter social media pages. And also, I'm going to type it in a minute. You can find us as Proceed NCTSTA. That's our social media handle. You can enter that in any of our social media pages. That's Proceed NCTSTA, and you will find our pages. And then you can use our hashtag to make any comments, post pictures, or interact with us, or ask us any questions. So in a moment, I'm going to be introducing our featured presenter for today. But just before that, we'd like to know where you're contacting us from and what your role is within your organization. So I'm going to just do two very brief polls that I would like for you to answer, and then we're going to continue with our session. So please let us know which region of the United States you're contacting us from today. I'll give you a couple of moments to make your selection, and then we'll move to the next poll. Just a couple of more moments. Okay, thank you. So it seems that a good portion of you are calling from the Northeast region of the United States, but we have representation from all regions, West, Midwest, South, and of course the Caribbean region. So thank you so much for joining us today. And the second poll question is, we would like to know, what is your role within your organization? Are you upper management, executive director, deputy director? Are you a director of programs or program coordinator? Are you a clinical director, case manager? And if none of these are what your role is, please use the chat box to let us know what you do at your organization. Okay, another moment, and I'll close the poll and share the results. Thank you so much. Well, as you can see, many of you are director of programs or program coordinators. So thank you so much. Now we're going to, that gives us, just lets us know your role that way in case we need to fine tune any information or follow up with some additional resources that'll make it easier. So thank you so much. Okay, well, today's session is called Steps to Advancing Health Equity and Reducing Disparities. And our featured presenter for today is Dr. Giselle Pemberton. So, Dr. Pemberton is a public health leader with 2 decades of experience of building sustainable public health programs that respond to the needs of countries and communities. Her passion for public health and social justice, combined with her expertise in organizational development, implementation research and science, and culturally competent health services, has distinguished Dr. Pemberton as a leader in the field. She is currently employed here at Proceeds National Center for Training Support and Technical Assistance as the director, and she earned her doctoral degree in public health from the University of North Carolina, Chapel Hill, and her master's of public health degree from Rutgers University. So we are pleased to have our very own Dr. Giselle Pemberton provide the presentation for today. And I am going to go ahead and open up her line. Just 1 second. Okay, my apologies. We're just working on making sure that Dr. Giselle Pemberton's line is unmuted. If you can just cooperate with us and just give us one additional moment. Thank you so much. Okay, everyone, if you can just hold on, I truly apologize. We will be getting this going in just another minute. Our apologies, sincerely.
Hello?
Okay, it seems that we are right. Okay, we are right on target. Dr. Giselle Pemberton, I hear audio, so please continue. I'm going to turn over the presentation to Dr. Giselle Pemberton. Thank you so much. And Giselle, you are on.
Okay, thank you. I really apologize. There's 22 people on, and I'm having technical difficulties. It always happens when you least expect it. But thank you for your patience, and again, my apologies. It was actually on my end with my computer remotely. First of all, thanks for joining the second webinar series, Steps to Advancing Health Equity and Reducing Disparities. You can see that we have a couple of learning objectives today. We're going to be reviewing the concept of health equity, and the national standards for class and their application to health services delivery. We're going to talk about some practical steps that organizations can take to advance health equity and reduce disparities. And I'm also going to provide some resources and tools that you can that you can access to help facilitate the integration of health equity into your agency's culture, programs, and services. So for the next about 35 to 40 minutes, I'm going to go through a lot of information. I will say that we're sort of jam-packed, so what I'm hoping is that, I'm not sure if Brenda mentioned this, but all the information from this presentation is downloadable. I think you go to materials, you click that materials tab in the control panel, and you will be able to access the entire PowerPoint and some handouts that I also asked that it be uploaded. So let's get started. So let's move on to the next slide. So we're going to dive right in. I'm going to get you guys we're going to start to interact really soon. So my question is health. When you think of health, what do you think of? What is it? What does it mean to you? If you could please just type your answers in the chat box, that would be great. And then we can, talk a little bit about it. So I'll give you a few minutes, well, not a few minutes, a few seconds, about 30 seconds. Please type what health means to you or how you view health. Yay, I got one response. Okay, they're coming in. I was getting a little nervous. Okay. All right, so I'm going to just read a few. I see that Andy said it's physical, mental, and emotional wellness. Robin Taylor, it's my everyday life, access to the things I need to be healthy in my surroundings and neighborhood. Megan says health is the connection between physical, mental, and spiritual well-being. I think Andy agrees with that as well. And Taylor says your health is your wealth. And Kevin provided a different definition, which is functioning and enjoying life to the best of your ability. These are excellent. Thank you so much for basically providing that. It's all of these things. And I'm going to talk a little bit about health and how the definition has evolved. And you might say, well, why are we discussing the definition of health? And hopefully you'll see the connection pretty soon. So from this slide, well, you can't see the slide because I didn't forward it. Okay, so from this slide, you can see that health has evolved. So, in ancient times, health was really centered around prayer and sacrifice. So I know, in reading this, it's so interesting because, for instance, in ancient Egypt, headaches were attributed to the action of demons and supernatural forces. So in order to appease the demons, you had to pray or make a sacrifice. So of course that was in the before Christ era or before Common Era, as it's now called. And then, sometime later we had the good old Hippocrates. I know everybody is familiar with the father of modern medicine, and his premise was that for the first time he moved away from magic and religion and established a relationship between like the environment and the person. So he believed that disease resulted from imbalances between certain bodily fluids, black bile, yellow bile, phlegm, and blood. Does anyone know what black bile is? I don't. But anyway, if you do type it in the chat box, because I will have learned something today. So then we evolved to the Common Era, and that's when, folks, physicians started really building on Hippocrates' ideas and looking at health a bit more broadly. So in addition to the 4 bodily fluids, Galen, who was a Roman Empire physician, a physician in the Roman Empire, noted that health included emotional and mental status. Basically, he talked about temperament and personality. These 4 bodily fluids influences temperament and personality. And then in 1948, so we jumped, okay? So in 1948, we have the World Health Organization, and they came up with this definition of complete physical, social, and mental well-being and the absence of disease. So as you can see, some of your responses in the previous slide definitely relate to maybe, definitely the World Health Organization definition, but also, the prayer and sacrifice, and perhaps something around temperament and personality and environment. So at the time WHO came up with this definition, it was seen as, revolutionary, and basically the concept of health came from, physical characteristics and whatnot, and it talked about behavioral and environmental considerations. So since 1948, believe it or not, the definition or the standard of health, or the definition of health that's most used, is the one by WHO: complete physical, social, mental well-being, and the absence of disease. This is just an interesting slide to show you the connection, again, with health and how we think about health. And it's I think I'm saying this right, Asclepius. It's the rod of Asclepius, which is an international symbol of medicine. So, here I go again, talking without shifting the slides. All right. So yeah, so this is the everyone's familiar with this. This is a symbol of medicine, and it's a reminder that, basically our interest in health and our ancient beliefs in health was, introduced by the deities of medicine and healing, which is very interesting. And, as I went through the definitions of health and how health has evolved, you see that even that first iteration of health in terms of prayer and sacrifice still remains. There is a spiritual connection, and I think some of you mentioned it in your post about what health means to you. All right, let's move on. So, again, health today has a lot to do with a state of complete physical, social, and mental well-being, and not merely the absence of disease or infirmity. And I have to tell you, the WHO definition, which I just stated, hasn't been wholly successful. I mean, many argue that, although it's well-intentioned, it remains unfulfilled due to the variety of issues, including dealing with the complex, evolving health conditions and environmental conditions that we deal with. And some people say, it's actually a definition that's more closely related to happiness than health. So the critics maintain that while health may be considered a human right, happiness, if it's really a happiness definition, then it's more difficult and more vulnerable or subjective, to opinion. So we have a couple other people who emerged post-WHO with some alternative definitions. I know many of you have probably heard about Maslow's hierarchy of needs, right? So Maslow is all into, let's meet your basic basic needs first, your physical, your safety, esteem, and self-actualization. It should say actualization, so my apologies. Then we have Bircher, which Bircher came up with, when we started looking at the cost of healthcare, especially in this country, and the outcomes that we were having, Bircher said, you know what, I don't know if we can really keep up with this state of complete physical, social, and mental well-being. So he started talking about, the individual's age, culture, and personal responsibility, which again goes back to behavior and whatnot. Huber and colleagues later on talked about a person's ability to adapt and self-manage in the face of social, physical, and emotional challenges. So these are all really interesting concepts. Next slide, please. So again, we talked about health being a fundamental human right. And my question to you is, are we there yet? So again, can you just type your responses in the chat? There are 3 options: yes, no, and somewhat. Or if you want to make a comment, that's fine as well.
I see a lot of no's.
Absolutely not. I see a nose. Nope, absolutely not. So we have a lot of people who are like, exactly. We know that we have so much work to do. And the reason why I went into the definition of health is that the promotion of health is affected by the differences in the definition of health. So for instance, health in its most simple form as the absence of disease does not consider what we know impacts health. Social conditions, the environment, the political context in which health or susceptibility to diseases occur. So we're talking about the definition also influences how we approach health and what we look for as the outcomes of quote unquote health. And I see that Gita says, no, many people live in poverty without access to the opportunity for better health. And you're absolutely right. So thank you for that. Thank you for all your responses. And health is much bigger than the issue of healthcare. So we know that, right? And we know that health is social and political and economic. And it really speaks to a nation's survival, and we know that good health is a result of multiple factors, including, social, economic, and physical environment, individual behaviors, genetics, and access to systems such as education and healthcare. So health in its purest form is all encompassing, and better health really offers quality of life and higher levels of function and productivity that benefits individuals and families and communities as a whole. So how do we achieve that? How do we get to expanding our definition of health and making sure that the communities that we serve receive the best health possible, right? So let's look at the concept of health equity. And next slide, please. So I'm just going to go over this really quickly because I know we have a lot more to talk about. So basically, this is a definition from the Robert Wood Johnson Foundation, and it talks about health as a fair and just opportunity to be as healthy as possible, removing obstacles such as poverty, discrimination and their consequences, powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. Equity is the absence of avoidable, unfair, and remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by the other means of stratification. So we're talking about, everyone reaching their best potential as it pertains to health, as it pertains to the concept of health. Okay? So next slide, please. These are just some of the factors that influence health, and we know race, ethnicity, sex, sexual identity, all these pieces on this chart here, all the words on this chart mean something, and they all contribute to an individual's ability to achieve good health. So we have a lot to think about. Next slide, please. So I absolutely love this quote because it really provided a shift in perspective from health being something that solely focused on the individual and their actions. We know so many times, even in our prevention programs, we talk about health as if it exists in a vacuum. We think about the individual and what they should do versus sometimes, what else do we need to make sure that people can be healthy, like, for instance, if we're talking about HIV prevention and, you say, hey, we want you to, use clean needles if you inject drugs, but then if you're found with a needle, you're punished for it. The criminalization, so it's these things that we have to think about health in a broader context. So the quote says, despite a growing body of research and clear evidence of the influences of systems and structures on population health, the dominant understanding of health inequities, which really is supported by our public health narrative on what creates health, the complete blah, 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 as per WHO, right? And it continues to be focused on the receipt of healthcare services and on the behavioral choices of individuals. So we know folks show up in our community. We know the most common chronic conditions in the U.S. We have heart disease, diabetes, obesity. So most times we focus on the behavioral choices of people rather than on the historical landscape of policy systems and environments that create structural inequities and limit opportunities for health. And perhaps one example of that, or maybe I should ask, can anyone think of an example of that? So let's say you have the issue of obesity, right? Besides someone eating too much, white flour, bad carbohydrates, what is another possible reason that obesity might be more common in certain neighborhoods and among certain socioeconomic groups or cultural groups than others? Anyone please just jot your answer in the chat box.
Giselle, can you just repeat the question one more time?
Yes, sure. My question was, what else can contribute to obesity in a community, for instance, besides just one's personal behaviors?
Okay, great.
Yes. So Kevin Sitter, thank you so much. You mentioned depression, you mentioned lack of resources and poor access to healthy foods, and that's excellent. I was really going for the poor access to healthy foods, and exactly, it's coming, nutrient poor geographic areas and the lack of nutritional guidelines, walkability. So we know that if you don't have sidewalks or safe parks, people aren't going to go out to exercise. Okay, so we also know that there are food deserts where people have to go, long distances to get fresh fruits and vegetables, or, the most they can get from the bodega might be an apple, that's been sitting on the shelf forever. So again, as we talk about health equity, it's talking about more than just the disease that we're presented with or the condition, because I think most of us in healthcare at Proceed, our programs are separated by, counseling, HIV, substance abuse prevention, and again, so much of it is focused on behavior. So anyway, let's move on and talk about how we can move forward. And I see transportation. Yes, that's a huge, huge issue. So, in other words, this slide talks about disparity. I like to talk about health equity, but of course, health equity is related to health disparities. Health equity is the ethical and human rights or value that motivates us to eliminate health disparities. I think health inequities, are different in health status are differences in health status between more socially advantaged and less socially advantaged groups caused by systemic differences in social conditions and processes that effectively determine health. So, health inequities are not only unnecessary and avoidable, but they are also unfair and unjust. So we already talked about that. Next slide, please. So achieving equity, again, we talk about part of achieving equity in health. It depends on living and working conditions and other resources that, enable people to be as healthy as possible. So we really, again, have to broaden our definition. Let's move on, Brenda, because I'm very cognizant of time. Culture and health, what's the connection? So, okay, so can you guys go back, please? Yes.
Sorry.
So that's okay. My question to the group of really great participants who seem very engaged is, can you take a moment and answer in the chat box what you think the connection may be between culture and health? What culture has to do with it? Sort of like play on Tina Turner. Yeah, I see Kevin's response, and I guess that's why I chuckle. I guess it's mom made me clean my plate, so meaning that you're used to having to eat every single thing, even if after you're full. Is that where you're going, Kevin? And Gita says culture set norms on what is considered to be healthy. Excellent. Thank you so much. So yes, culture influences how our clients, patients, depending on where you work, understand health concepts and how they may take care of their health and how they make decisions about, related to their health. So Andy says our attitudes toward wellness as well as morbidities affect how we respond to the condition of human bodies and how we talk about them. That's excellent. I think I'm going to have to take that as a quote, Andy. Thank you. That's great. It's a great connection. All right, next slide, please. Now, I know if you've been attending the webinar series, you've probably seen this slide before. I am not going to go into cultural competence, but what I want to say is that cultural competence is one strategy for health equity, right? So we know that cultural competence is a set of congruent practices, skills, attitudes, policies, which come together in a system, or in this case, in our agencies or among professionals that enable the system or those professionals to work effectively in cross-cultural situations. So think of cultural competence as, just one part of health equity. Obviously, we're talking about a lot more, than that. Next slide, please. All right, so let's talk about linguistic competence, which so many of us have challenges with. Just yesterday, I said to my coworkers at Proceed, I said, you know what? Let's think about health equity, and let's think about our community. What gaps do you see in terms of the services that we provide to our community? Or who's not getting served? Who's not being reached? Where can we improve? And at first folks are like, well, we offer bilingual services, which is, Proceed serves a probably predominantly Latino clientele. And another colleague said, well, wait a second, we don't have enough Creole speakers within the agency, and we know just from observation, which is usually the fact, right? We all know our communities as well as the data that we have a growing Haitian population in Elizabeth. So that's one area where we're like, hey, while we might be linguistically competent in serving folks who where Spanish is their primary language, we're not so competent when it comes to serving folks where Creole is their primary language. So again, health equity is also about looking at the data and how things are evolving in your community and figuring out a response to that. Next slide, please. So we make the distinction here between individual and organizational cultural competence because we know that individual competence is just about me or you, right? So I know that I try my best to ask questions if I don't know the answer. I also do my research beforehand because I know for a lot of people, and especially some communities of color or I know when we work with our trans brothers and sisters, sometimes they say, well, have you done any research? And it's absolutely, but then there's still questions I may need to ask. So, that's my individual competence. And it doesn't matter how competent I am, but we know that we need to expand our competence and it needs to be at the organizational level, not only in terms of the clients we see, but in our policies and in our personnel and in the way we deliver services and share information and evaluate programs. So these are some of the differences I just wanted to point out, and there's a reason for that. So, this next slide, please. So this cartoon pretty much says, my job is to help you get care and treatment. And it's an example of cultural competence. One person is aware of their own culture and their worldview, their values, beliefs, and behaviors, and makes every attempt to engage and provide quality services to diverse groups. So this is individual cultural competence. But in my work, I really, try to encourage agencies, because we serve organizations, healthcare organizations, more so than individuals, to move beyond individual cultural competence. That's absolutely necessary. I think by you, for instance, participating in this call, it shows, that you're definitely invested in thinking about health equity at a greater level. But at the same time, we know that, next slide, please, that we need organizational buy-in, resources, input to have a certain level of competence, right? So successfully integrating cultural competence into an agency's culture might be best achieved by, incorporating it into an organization's infrastructure, for example, in its human resources or continuous quality improvement methods, or creating cultural competence specific infrastructure which formalizes cultural competence activities like planning, reporting, and accountability. So that's where we're thinking of. So let's move on. I think everyone already knows this. This is just, culture is almost a part of everything. As you can see, when we talked about the things that, factors that influence equity, you see a lot of similar items, of course, because we know that we all come to the table with, a number of things on our plate. We come with our identities, and that impacts how we hear the message, how we take the message and put it into action or not, and what our expectations are. Okay, next slide. So the provision, so what's the connection between health equity and cultural competence? Well, it's the provision of culturally and linguistically appropriate health services. Cultural competence is an evidence-based strategy. Remember I said, it's not the only strategy, obviously. We talked about, our grand, how broad health can be and how the definition of health definitely makes, impacts how we operationalize our efforts. So let's move on, please. Again, if you were in the first webinar, you're probably familiar with CLAS. Can you just type yes or no if you've ever, used the CLAS standards, or you've heard about it, or you've been trained in it, or your organization uses the CLAS standards? Rachel says yes. We have a lot of yeses. That's great. But we have some folks who say they're learning more. And I have to tell you, this group is a lot more savvy than a lot of the folks that we've trained in this topic. Like, most people have never heard of it. So I'm not going to get into CLAS too much. There are resources that will link you back to CLAS. But basically, the standards are intended to advance health equity, improve quality, and help eliminate healthcare disparities. And really, that's the crux of it, and that's why it's so important as a guide and a blueprint for helping our organizations advance health equity and moving beyond just the individual. Next slide, please.
Giselle, I just want to note really quickly that in your materials bar in the console, I did place the link to the Think Cultural Health website that has all of the information on the CLAS standards and some tools in English and in Spanish, so that you could access that, after you end this session, so that you could learn more if you want to learn more.
Okay. Brenda, thank you so much. I am so conscious of time, and I know we lost a couple minutes because of my tardiness. So, Standard 1 is projected. I'm going to review that really quickly, because Standard 1 is all the other standards feed into Standard 1, which is around providing effective, equitable, understandable, and respectful quality care and services that are responsive to the diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. Next slide, please. And again, these standards should be in the handout, so you can get a chance to look at them. But I guess the main issue, as I mentioned, standards 2 through 15 feed into Standard 1, which I just highlighted. And there's 3 specific themes. It's around governance and leadership, communication and language access and engagement, and continuous quality improvement. So most of you who are familiar with the CLAS standards can look at this and say, okay, we need to ask questions that pertain to that. But how do you take this and these standards and translate it into practice? I guess that's the question everyone has and has difficulty with. It's how do you operationalize this stuff? So next slide, please. I'm going to skip over that. Next slide. Oh, okay. So when we talk about health equity in action, this is the Robert Wood Johnson Foundation. I love that site. I think it provides so much good information, and it is listed as a resource at the end of the presentation. So when we talk about those of us who work in healthcare, these are some steps that we can take in terms of putting health equity in action. And I would say this is more individualized. So we can adopt new vital signs to screen for non-medical factors influencing health. So can you type in the chat box what a non-medical factor influencing health may be?
A non-medical factor that influences health.
Right. Mm-hmm. Wow. Mm-hmm. So there's zip code. So true. That's environment. Stress provoked by stigma. Absolutely. Poverty. I mean, so many of the factors that influence health, education, it has nothing to do with that concept of disease, solely the concept of disease, right? So, again, just thinking about how we put health equity in action, we know that class also promotes communication, language and communication. So helping low-income and non-English speaking patients or clients get the care they need. We talk about stigma. I think somebody said stigma. I think it was Kevin. So it's guarding against potential for bias to influence medical care, and making sure elderly women and racial and ethnic minorities are adequately represented in clinical trials. I know I've been working in HIV for 20 something years, and in the beginning there were no clinical trials that would accept women. Why? Because they were really uncertain how the drugs would influence pregnancy. Even when women said, you know what, I am not planning to be pregnant, or for whatever reason I'm past that stage or whatever it was, but there were no clinical trials for women until much later on. And of course, most of us know that all the conversations now, as far as health is concerned and health interventions are concerned, is that we're really looking at adverse childhood experiences and trauma-informed care. Next slide, please. So my slides might be a little bit misplaced because I think this slide, that's why I paused for a second. This slide provides some guidance on how to operationalize class, that primary standard and the 14 other standards, right? So when we look at the domains like organizational values, we're thinking about mission and vision statements. Does it reflect a commitment to cultural competence? I mean, some agencies create a cultural competence strategic plan, and actually a lot of health departments are doing it. I don't know if there are any health department staff on the call, but I wonder if you guys have a cultural competence strategic plan or health equity strategic plan. If you do, just type yes. But a lot of agencies are doing that. Leadership and governance, it's a way of looking at, do you mentor people? Is there a mentoring program? Does your staff reflect the community, not only in terms of race and ethnicity, but also all the plethora of factors that influence health, as we showed on previous slides. So we can take time and look at this later on, but let's move on because I really want to touch bases with some of the other slides. Let's move on. That's pretty much class again. Now, I really wanted to point out this particular resource. It's really, I thought, really forward thinking in terms of what we talked about at the beginning about health equity. The link is at the end of the PowerPoint that you have a copy of, but Brenda, can you move forward so we could talk about it a little bit? So here I'm going to ask, I think, what is my last question to you, which is, what are your greatest concerns when it comes to putting health equity into practice? Kevin says justifiable anger at the historical and current inequities, aren't there? And there are so many, Kevin, so I totally get that and I understand it. Okay, so Andy talks about evaluating meaningful community participation during the process of developing community-level intervention. So, right, it's not just about representation, but actual participation. And because we all know that our communities should be, involved in the interventions that we develop for them, but it should be with them. So, thank you. Brenda says true commitment from organization, staff, and management. Absolutely, absolutely. These are all really valid. And Kevin mentions resistance to change. Yeah, these are huge things. Evolving process of continuous improvement is needed. Continuous quality improvement is needed. Absolutely, Megan. Thank you. Okay, so I think these are great. And next slide, please. Next slide. I actually wanted to get past it. So, Gita, you mentioned that lack of manpower to get the process going. Absolutely. I think the time commitment is something that should be recognized, because it cannot happen in one webinar, in an hour, right? So it's like, what do you do after this? What happens after? So again, this learning action tool is a part of the operationalizing health equity document. I think 2 slides prior, Brenda, if you don't mind, just to make the connection. Sure. Yeah, so it's part of this tool. And can you go back? Great. So there are 7 foundational practices that we say can advance health equity in public health practice. What's interesting is this resource, as you will see, is very specific to health departments. But as I went through the document and at Proceed, as we try to incorporate some of these foundational practices, it's really interesting because it's absolutely still relevant to community-based organizations and healthcare organizations. And I would say all organizations. It needs to be tweaked. It may need to be tweaked somewhat, but these 7 foundational practices absolutely help. So the first one, for instance, is expanding your understanding of health in words and action. And if you think about it, this is where we get back to, Brenda, can you move forward? So expanding and understanding health in words and actions. Here we're talking about expanding our definition of health as we provide services, and that's why we talked about it in the beginning. We need to talk about whether our organization uses its mission and its vision and value statements to communicate and support an understanding of structural and systems-based inequities that may contribute to poor birth and health outcomes. So in the guide that I referenced, there are a series of questions around the 4 items listed here: data, use of data, developing leadership, aligning actions and investments, that you can look at after this call, because we just don't have enough time to go into it in the way that I would want to go into this, to look at how you can expand the understanding of health in words and actions. It also means bringing the issues of health equity to the forefront. Because, folks get so uncomfortable if you ever, with racial and ethnic disparities in particular, right? Because, again, nobody wants to be, a pariah, right? So, again, but it's so necessary, because the truth is most of our disparities, there's great disparities in terms of racial and ethnic differences, just like there are with LGBTQ health and women's health. Like, we know that our entire beings affect how we receive the services that we receive and how we receive those services. So next slide, please. Wow. Okay. The second slide is about assessing the influence and policy context. So let's just move to the third bullet, which is something very concrete. No, go back, please. Sorry.
I apologize. Okay.
Yeah, that's okay. It's the third bullet, and here we're talking about looking at our agency's internal policies, programs, and systems using an equity lens. Again, the reference I provided goes through all of these things. So we're talking about hiring and human resources, workforce development, the way we get data, the way we use data, which to me is huge, budgeting and resource allocation. I always say to our team, health equity is like world peace. Everyone talks about it, but no one wants to invest in it, in real concrete ways. And not just government, but I mean across the board, we don't do enough to invest in health equity. Okay, next slide, please. So I am cognizant of the time. So we're talking about also leading with an equity focus, which means that we need to get our stakeholders engaged and commit resources and foster health. And foster health equity leadership. It's not based on a position, but more so on the commitment to advance health equity. Let's move forward. So I'm just going to go through this really quick. And data to advance health equity. I would like to challenge everyone on the call to really think about the data you collect, what you're asking, and how the data is being used. It's so important to think about that in terms of, you know, the questions that we ask people to respond to and what we do with this, you know, with the information. A lot of times, so many of us collect data that we never use. So let's move on. Someone talked about continuous learning and continuous quality improvement. So this is talking about that, the way that we make sure that staff within our agencies, from the receptionist to the, you know, board president, receives training, for instance. You know, opportunities for professional development and workforce development. And of course, CQI, you know, strategies for ongoing learning, innovation, and improvement, making sure that everyone has a say, your staff, the folks you serve, leadership, and everyone's, you know, say is really considered in a real way. Okay, next slide, please. Our next webinar is actually on successful partnerships that strengthen community capacity. I happen to think this is one of the strongest ways that we can support equity. We know that health is not just about, you know, the specific field that we work in. So it's absolutely, you know, mandatory that we expand our partnerships, and not only in healthcare, but non-health, you know, with non-healthcare entities. So I would say in HIV prevention, that's probably been one of the stronger, you know, that's been strong in terms of having to reach beyond, quote unquote, you know, just healthcare. You know, we've had to work with people, you know, incarcerated populations, and we've had to, you know, expand to, you know, doing HIV testing at a DMV, Department of Motor Vehicles. So it's just about how do we reach the people that we need to reach? How do we strengthen partnerships? Housing is also huge. So we know that we need relationships with people and groups and professional organizations and advocacy organizations. Next slide, please. I will wrap up in a few minutes. Thank you for being patient. And of course, assuring the strategic and targeted use of resources. So it's about investment. And someone mentioned time, the lack of manpower to get the process started. This is really, you know, the last webinar we talked about what are the benefits of pursuing a health equity agenda within an organization, because it absolutely takes time and it absolutely takes follow-up. So what type of what resources are we willing to invest in order to get the outcomes that we want? And how are we going to track those, track our progress and think about how to maximize the impact of the resources that we invest, so that, you know, we get the most out of it. Next slide, please. So this is a summary, and it pretty much, you know, duplicates what I just talked about. But we talk about here, what I did was break it down into internally focused practices within your organization to advance health equity. And the next slide shows the external focused practices. So again, these things, as you can tell, feed into those 7 foundational strategies listed in terms of advancing health equity. Next slide, please. And I hope that you take the chance, you know, the time to review that. And I just want to end here, which is really of all forms of inequality, injustice in healthcare is the most shocking and inhumane. And remember, we know health is more than healthcare, but we're all in healthcare. So we certainly have, we invest in that. So, this is a quote by Martin Luther King. It's what keeps me on my toes in terms of working to advance health equity and address disparities. And I thank you all. Next slide, please. So for those of you who are still on, there are a couple of resources. They're listed. You can click on the website or type in the website. I definitely want to point out, go back to Advancing Health Equity, please. This resource, Advancing Health and Well-Being, it is, you can request a free book which provides practical steps towards, again, operationalizing and achieving health equity, and provides examples from a number of disciplines across the board. So you may want to check out this resource. Next slide, please. I'm just going to point out the ones that I think are really important. Project Implicit. If anyone on the phone has heard of Project Implicit, just type yes. But I think it's a great starting point. If you're thinking about how you want to invest and empower and strengthen your skills to achieve health equity, then look at Project Implicit. It's absolutely a great resource, and I actually just did the test that they provide, and it's very interesting. Basically, it kind of tells you, hey, what sort of implicit biases do you have or need to address. So it's great. And again, these resources pretty much reiterate a lot of what was presented today, but it's all around achieving health equity and thinking about how you can operationalize class and move an equity agenda forward for your organization. Next slide, please.
Oops. I'm sorry.
Yeah. Well, that's it for us. I know it's 3:06. I am so sorry that we have not had a chance for questions, but if anyone has a pressing question, please type it in. For those of you who probably need to run, there will be an evaluation form once you log out. Please complete the form. We need your feedback. Thank you, Kevin. We need your feedback. But if you have a pressing question, please feel free. And Brenda will take over, I think, for the rest of those. But thank you so much for the rest of the webinar to close out.
Yes, let us know if you have any questions. But in the meantime, there is one final session to the webinar series, which is July 31st, 2 p.m., same time, 2 to 3 p.m. And we're going to be focusing on developing strategic alliances to achieve health equity in your community. So here is the description once again and the registration link. If you haven't done so already, there is still space and time for you to register. We'd encourage you to do that. And again, if you would like a copy of the presentation, or you didn't think of a question at the moment, but sometimes, I know for me, sometimes I think of questions afterwards, you can email myself or Mr. Miguel Taveras, who's our other program manager, and we would be happy to address or provide you any additional resources that you may need. Giselle, if you don't have any additional comments, I am going to close your line. Do you have a closing comment?
Well, I just want to, this was a great group. Thank you for your participation and input as I just typed into the chat box. I know health equity is huge, especially when we think about our current climate in this country. But it's those of us who, do the work and who are brave and who see health in a larger context that are going to be able to, make changes, small changes, one drop, the ocean, one drop in the ocean, builds. So let's keep doing what we do. Thank you.
Thank you. Okay, so let's give Dr. Giselle Pemberton a virtual round of applause by typing applause in your chat box. And we can still respond to any questions, or as you saw, our email addresses. We can respond to them as well via email directly one-to-one. So I am aware of time, so this ends our presentation for today, and we hope that all of you will join us for the third session in the series, and enjoy the rest of your day. Have a great day.